Welcome to the deep dive.
Hey there.
So this is where we take source material, could
Yeah.
be notes, articles, you name it, and we really dig in.
Yeah, we try to pull out the absolute key insights, the really useful stuff, specifically for you.
Think of it as cutting through the noise, getting you the high-yield info fast.
Exactly, helping it stick.
Today we're diving into some specific source material. MSRA Pediatric Revision Notes.
Right. And our mission today is pretty focused. We're zoning in on one really important condition from those notes.
That's whooping cough, or pertussis, as it's also known.
Yep. We're going to break down what these notes say, make it super clear, high yield for your revision, and basically cut out anything non-essential.
Okay, sounds good. It's definitely a condition that pops up.
It does. So let's start right at the beginning, the core definition you absolutely need to know.
Okay, let's unpack pertussis. So fundamentally, it's an infection, right?
Sure.
Respiratory. And it's highly contagious.
Highly contagious, yeah. And the specific culprit is a bacterium, Bordetella pertussis.
Got it. Bordetella pertussis. And the thing that really makes it stand out is, well, the cough.
Exactly. Those severe coughing fits, they can be quite scary. And often followed by that very distinctive whooping sound when someone gasps for air afterward.
That horrible sound, yeah. And from a public health angle.
Ah, yes. Crucially, in the UK, it's a notifiable disease. That's really important.
Right, so doctors have to report suspected cases. Helps track outbreaks.
Precisely. And the notes mentioned, just to give you a sense of scale, we still see roughly 1,000 cases reported each year here in the UK.
1,000. That might be higher than some people think, actually.
It might. Shows it hasn't gone away. So that's the what. Now, how do you actually get it? The cause, the etiology.
Well, you mentioned the bacterium.
Yeah, it's simply down to Bordetella pertussis. That's the cause.
And how does it spread? Person to person.
Yep. The usual respiratory route, tiny droplets flying through the air when someone who's infected coughs or sneezes. Pretty standard for bugs like this.
Okay, simple enough.
Yeah.
Which leads us to who's most at risk.
The notes are very clear here. The most vulnerable group, by far, is infants and young children.
Little ones. Why them particularly?
They face the highest risk of serious complications. Their airways are smaller, their immune systems aren't fully developed. It just hits them harder.
Makes sense. Anyone else specifically mentioned?
Yeah, also people who are unvaccinated or maybe haven't completed their full vaccination course, they're just more susceptible.
Stands to reason. And I guess being near someone who has it.
Absolutely. Close contact with someone infected massively increases your chances of catching it. Transmission risk goes way up.
Okay, so we know who gets it and how. Let's get into the mechanism. The pathophysiology. How does this tiny bacterium cause such chaos?
Right, this is where it gets interesting. So B. pertussis isn't just floating around, it actually physically attaches itself to the lining of your respiratory tract. It latches on.
Okay, it sticks itself there.
And then it starts producing toxins. These are the real troublemakers. These toxins specifically damage the cilia.
Ah, the cilia, right? Those are the tiny little hairs lining our airways. They're meant to sweep mucus and debris out, aren't they? Like a little cleaning crew?
Exactly like a cleaning crew. Or maybe like a conveyor belt, constantly moving stuff upwards and out. But these pertussis toxins basically sabotage that system. They damage the cilia, gum up the works.
So the conveyor belt breaks down.
Pretty much. And not only that, the damage also triggers more mucus production, and it causes inflammation, which narrows the airways.
Wow. Okay, so you've got a broken cleaning system, extra mucus, and narrower pipes.
You got it. And that combination is what leads to those really severe, uncontrollable coughing fits. The body's desperately trying to clear the airways, to force air through.
That paints a really clear picture of why the cough is so bad.
Okay.
So given those symptoms, especially early on, what else might look like this? The differential diagnosis.
Yeah, this is crucial because early symptoms can be really nonspecific. You need to consider other things.
Like, could it just be a nasty bronchitis? Or maybe pneumonia?
Definitely. Bronchitis, pneumonia, other common viral respiratory illnesses. Even something like asthma could present similarly, especially before that classic whoop sound appears.
So it's easy to mistake it initially.
Very easy, which is why, for your revision, you need that list of differentials in mind. Don't just jump to pertussis if someone has a bad cough, especially in the early stages. Think broader.
Good point. Okay, let's zoom out a bit. Epidemiology. Where does it happen? Who gets it? Are there patterns?
So focusing on the UK context, the notes mention we see these periodic outbreaks. The number of cases varies year to year.
And we already touched on the high-risk groups, unvaccinated, partially vaccinated, and especially infants under 6 months.
Right, but what's really interesting and a key takeaway from these notes is the pattern. It tends to be cyclical.
Cyclical, how so?
Pertussis often peaks roughly every 3 to 4 years, and even though vaccination made a huge difference historically, reducing overall cases massively, epidemics still happen.
Even after the vaccine was introduced.
Yep. And another really important point the notes make, it's not just a disease of babies anymore. Adolescents and adults get it too. And this is where some really surprising data comes in.
Oh, what kind of data?
Well, the notes highlight the 2012 outbreak. That one particularly hit infants under 3 months old really hard. And it was that data, that specific outbreak, that directly led to introducing the vaccination program for pregnant women.
Wow, so a direct line from seeing who was affected to changing public health policy.
Exactly. A real example of surveillance informing action. But then, look at the more recent data mentioned for 2019.
Okay, what did that show?
In England, there were over 3,600 cases reported. And get this, 74%, nearly 3/4 were in people aged 15 or older.
74%. In teenagers and adults. That kind of flips the common perception, doesn't it?
It absolutely does. It really suggests that older individuals, adults, might be acting as a reservoir, maybe spreading it to vulnerable infants without even realizing they have pertussis.
Huh. And is it often missed?
The notes strongly suggest it's underdiagnosed. They cite a study, this is quite striking, finding that about 1 in 5 school children with a persistent cough had evidence of a recent pertussis infection.
1 in 5. With just a persistent cough.
Yep. And, get this, even if they had been vaccinated.
Wow. Okay, that's a huge point for revision. Vaccinated kids still getting it, potentially.
Exactly. And it naturally leads to the question raised in the notes about waning immunity and whether, maybe a booster dose is needed for older age groups, not just the little ones.
Right, because the protection might wear off.
Yeah.
This whole picture is way more complex than just sick babies.
Definitely. So, okay, let's move on to what you actually see when someone has it, the clinical presentation. The notes break this down nicely into 3 stages.
3 stages. Okay, that sounds like something useful for remembering.
Absolutely crucial for recognizing it. They are the catarrhal, the paroxysmal, and the convalescent stages. Maybe think CPC.
CPC. Okay. Catarrhal, paroxysmal, convalescent. So that's the first one. Sounds like a cold.
Exactly right. It starts off very much like a common cold, runny nose, maybe some sneezing, a mild cough. But the key is that this cough gradually gets worse.
So it doesn't just stay like a mild cold.
No. It progresses into the second stage, the paroxysmal stage. And this is the really characteristic, dramatic part.
Okay, paroxysmal. This is where the bad coughing fits happen.
Precisely. Severe, prolonged fits of coughing. And this is where you get those key features, that classic whooping sound as they gasp for air after a fit.
Inspiratory whoop.
Yes, and often vomiting triggered by the sheer force of the coughing that's called post-tussive vomiting. And understandably, the person is just wiped out, exhausted afterwards.
CPC. Catarrhal paroxysmal. Oh, okay. And the notes mention diagnostic criteria based on this stage.
They do. Essentially, you'd suspect it if someone has an acute cough lasting 14 days or more. PLOUS, one of those key features. The paroxysmal nature of the cough itself, that inspiratory whoop. The post-tussive vomiting, or, and this is really important in infants' apnoeic attacks, where they might actually stop breathing for short periods.
Scary stuff, especially the apnea. And you'd consider their vaccination history too, I assume.
Definitely. Need to factor that in.
How long does this whole awful process usually last?
Well, the notes say the main illness typically lasts about 6 to 8 weeks. And here's a really critical point to remember for revision. That's even with antibiotics.
Wait, even if they get antibiotics, it can still last that long?
Yes. The severity can vary a lot, of course, especially with age. Infants usually having the toughest time.
Okay, so CPC, catarrhal, cold-like, paroxysmal, the bad fits, whoop, vomiting.
Mm-hmm.
What's the last stage? Convalescent.
That's the recovery phase. Symptoms gradually start to improve. The fits become less severe and less frequent.
Mm-hmm.
But the cough can stick around for ages.
How long is ages?
It can linger for 2 to 3 months sometimes. That's why it has that nickname.
The 100-day cough.
Exactly. That really drives home how long it can persist.
Okay, a 100-day cough. That's memorable. If you were examining someone, say, in that paroxysmal stage, what might you actually find?
Well, particularly in infants, they might look quite unwell, especially during or just after a coughing fit. The intense coughing, as we said, can cause vomiting. It can also cause tiny burst blood vessels in the whites of the eyes. Those are subconjunctival hemorrhages. just from the pressure.
Wow. Any other specific physical signs mentioned?
Yes, the notes highlight a key feature of the cough itself. It often sounds like the person is coughing until their lungs are completely empty, before they can take that desperate next breath in.
Which causes the whoop.
Exactly. That's the mechanism. Now, quick word on infectivity.
Okay. We know it spreads via droplets. Incubation is what, 7 to 20 days?
Yep. But the crucial thing for public health, mentioned in the notes, is when they're most infectious.
When's that?
It's highest during that early catarrhal stage.
Oh, right. When it just looks like a standard cold.
Exactly. That makes it so difficult to control because people are spreading it before anyone even suspects it's pertussis.
How long do they stay infectious?
Generally, for people outside their household, they're considered non-infectious after about 3 weeks from when the cough started. But, and this is vital for management starting, the right antibiotics cuts that down dramatically.
How much?
They become non-infectious to others just 5 days after starting treatment.
5 days versus 3 weeks. Big difference.
Huge difference, and that's why isolation is recommended for diagnosed cases to stop the spread.
That timing around infectivity and antibiotics is definitely a key revision point.
Right.
Okay, so you suspect it clinically. How do you actually confirm it? Investigations.
Right. The goal of investigations is laboratory confirmation proving that Bordetella pertussis is actually there.
How do you test for it?
You usually collect samples like nasopharyngeal swabs, it swabs from the back of the nose or throat. Blood samples might also be used for certain tests like serology.
And what tests are commonly used now?
The notes say that modern techniques like PCR, which looks for the bacteria's genetic material, and serology, which looks for antibodies in the blood, are increasingly common and often preferred over traditional culture methods.
What about things like chest x-rays?
A chest x-ray might be done, but usually that's more to look for complications, like if you suspect pneumonia has developed. It's not typically used to diagnose the pertussis itself.
Got it. And specific tests mentioned.
Yeah, nasal swab culture is listed, but again, PCR and serology are highlighted as common now,
Right.
and we need to hammer this home again because it's a notifiable disease.
You notify Public Health England.
Yes, and you do that based on suspicion alone. You don't wait for the lab results to come back. Notifying promptly is a crucial public health step.
Okay, notify on suspicion. That's a clear action point. Do the notes say which test to use when?
Yes, it depends a bit on age and how long the cough has been going on. For instance, for older children, 5-16, with a cough over 2 weeks and no recent vaccine, oral fluid testing may be used. For adults, over 17, or younger kids, under 5, with a cough over 2 weeks, serology could be an option. Culture or specific antibody tests like pertussis toxin on IgG are also mentioned. And for very sick infants in hospital, PCR is specifically recommended.
So it's not one size fits all for testing. And always remember to notify Public Health.
Okay, let's talk management. How do we treat this, or maybe more importantly, prevent it?
Prevention is absolutely number one. And the key strategy, heavily emphasized in the notes, is immunization.
Right, the routine jabs for babies.
Exactly. Infants get vaccinated at 2, 3, and 4 months. Then there's a preschool booster around 3 to 5 years old. But, and this came directly out of that 2012 outbreak data we talked about, vaccinating pregnant women is now a massive part of the strategy.
Why pregnant women specifically? It protects the newborn baby during those first few vulnerable months before they can get their own jabs. The mother passes on some temporary immunity. It's hugely important.
That makes perfect sense. Okay, so immunization is key for prevention. What about managing someone who actually has it?
Well, for severe cases, especially in infants 6 months old or younger, hospital admission is often needed if they're very unwell or having breathing difficulties.
And notify the disease.
Yes, notify public health. Always. Now, about treatment. Antibiotics.
Okay, do they work? Do they stop that awful cough?
This is probably the most important point about antibiotics and pertussis for your revision, straight from these notes. Yes, antibiotics are used, usually macrolides like azithromycin, but they're mainly effective at doing one thing if started relatively early, within 21 days of the cough starting.
And what's that one thing?
Eradicating the bacteria and, crucially, limiting transmission, making the person less infectious to others.
Oh, sure, they don't actually make the cough go away faster if it's already established.
Generally, no. This is a common misconception, so let's pose that question. True or false, starting antibiotics will stop the characteristic whooping cough fits?
Based on what you just said and what the notes say, that's false.
Correct. False. The antibiotics don't usually change the course of the established illness much. That cough, the paroxysms, they're likely going to continue for weeks regardless, but the antibiotics do stop the person spreading it after about 5 days.
That's such a key distinction. Reduce spread, don't necessarily cure the cough faster.
Exactly. And because of that risk of spread, especially within families, close household contacts are often given antibiotics too. That's prophylaxis to stop them getting it and passing it on.
Okay. What about keeping kids out of school or nursery?
The guidance mentioned is exclusion. They need to stay off for 48 hours after starting antibiotics. If they don't get antibiotics, though, they need to be excluded for a full 21 days from when the cough started because they stay infectious for longer.
Makes sense. And what about treatments for the cough itself? Anything to ease those fits?
This is where the notes are quite clear and maybe a bit disheartening. Care is primarily supportive. There are basically no proven effective symptomatic treatments for the cough itself once it's going.
So no magic cough syrup is going to fix this.
Unfortunately not. It really highlights why prevention through vaccination is so vital.
The notes do list specific antibiotic choices, right?
Yes, they give some specifics. Clarithromycin is often used for the very young infants, under 1 month. For older children and non-pregnant adults, azithromycin or clarithromycin are common choices. For pregnant women, it's typically erythromycin. And there's an alternative, cotrimoxazole, if macrolides can't be used.
Okay. So summing up management, prevention via vaccination is king. Infants and pregnancy. If someone has it, notify, consider antibiotics within 3 weeks, mainly to reduce spread, offer prophylaxis to close contacts, school exclusion rules apply, and supportive care for the cough itself.
That's a great summary. Which brings us to the prognosis. What's the likely outcome?
It sounds like it really varies.
Massively. Depends heavily on the person's age, their vaccination status, and their general health.
And the highest risk is for the youngest babies.
Tragically, yes. Infants under 6 months old have the highest risk of severe disease, needing hospitalization, and they have a significantly higher mortality rate compared to older kids or adults. It's much more dangerous for them.
And even if things don't get that serious, the cough itself
Can go on for a very long time, months potentially. That 100-day cough isn't an exaggeration for some.
which again just reinforces the importance of prevention.
Absolutely. Vaccination, especially the maternal dose, is critical for improving the overall prognosis by preventing those really severe outcomes in the first place.
Yeah, just to reiterate the antibiotic point one last time.
They reduce transmission, but don't necessarily shorten the illness duration or severity for the individual once those coughing fits are well established.
Got it. Okay, finally, let's touch on complications. What are the potential serious problems that can arise from pertussis?
These are really the reasons why we take it so seriously, particularly in infants. The severe coughing itself can cause direct physical problems.
Like those eye hemorrhages you mentioned.
Yes, subconjunctival hemorrhages. But more seriously, pneumonia is a major complication, a secondary bacterial infection in the lungs.
That sounds nasty. Anything else?
You can get long-term lung damage, a condition called bronchiectasis, where the airways become permanently widened and damaged.
Okay, and neurological issues.
Yes, seizures can occur, often due to hypoxia, lack of oxygen during really severe prolonged coughing fits.
It's just the physical strain.
Yeah, the sheer force can sometimes lead to things like rib fractures or hernias developing because of the intense pressure changes in the body.
And are infants more prone to these too?
Definitely. Infants under 6 months are particularly vulnerable to the most severe complications like pneumonia and seizures.
So preventing these complications is a huge driver behind vaccination and trying to manage the illness effectively.
Absolutely. It's all about preventing these potentially devastating outcomes, especially in the most vulnerable.
Wow. Okay. We've covered a lot of ground there, really drilling down into pertussis based on these revision notes.
Yeah, from the bacterium itself, how it works, the CPC stages, how to spot it, test for it, manage it, right through to the prognosis and those serious complications.
We've tried to pull out those really high-yield facts, clarify things like the antibiotic role, and highlight some of that surprising epidemiology data about older age groups.
Hopefully making it clearer, more structured, and easier for you to retain for your revision without getting lost in all the detail.
Yeah, hopefully this deep dive has helped make those notes less dense and more digestible.
Make them come alive a bit, maybe. Help those key facts stick.
So as we finish up, here's something to maybe mull over, a provocative thought based on what we've discussed.
Oh.
Given everything we heard from the notes, that whooping cough can be underdiagnosed, that it significantly affects older teens and adults, and that even vaccinated people can get a persistent cough from it. What does that really tell us about the challenges we face in controlling infectious diseases like this? Does it suggest we need to keep adapting our strategies? Maybe thinking more about booster doses? Or even just how we approach investigating someone who comes in with a cough that just won't quit?
That's a really good point. It definitely shows that managing these diseases isn't static. We constantly need to look at the data and potentially adjust our approach based on who's getting sick and why. Food for thought.
Definitely something to think about. Now, if you are revising and looking for more materials or practice questions, perhaps like the true-false one we did.
Yeah, there are some great resources out there. For MSRA-specific revision, definitely check out passthemsra.com.
And also freemasari.com for more resources.
Both excellent sites.
Okay, that wraps up this deep dive on whooping cough. Thanks for joining us.
Yeah, hope that was useful. Until next time.